Balloon mitral valvuloplasty, or BMV, for treating patients with symptomatic mitral stenosis is a rarely done interventional procedure in the U.S. We have treated the bulk of patients in the symptomatic mitral stenosis pool back in the 80s and 90s, so now only occasionally do we see patients with rheumatic mitral stenosis. However, on a worldwide scale, MS is still a major source of patient disability, especially in younger women. So it comes as no surprise that the European Heart Journal has a report on optimal timing for doing a mitral valvuloplasty, essentially answering the question of whether it is better to treat patients with moderate MS or wait for a later stage of the disease. The authors compared long-term outcomes of early preemptive valvuloplasty and a conventional treatment strategy in about 250 consecutive patients, of which most, as expected, were women. This is not a randomized trial. The treatment was at the discretion of the attending physician. The investigators did a good job. There were no procedure-related deaths, and mitral valve area was increased to about 2 centimeters squared, as expected. During a median follow-up of 8.3 years, there were 3 cardiovascular deaths and 5 cerebral infarctions in the early valvuloplasty group, compared with 10 cardiovascular deaths, 12 cerebral infarctions, and 7 systemic embolic events in the conventionally treated group, which translates to an estimated actuarial 11-year event-free survival rate of 89% in the early treated group and 69% in the conventional group. They also reported 62 propensity-scored matched pairs in which the risk of a cardiovascular endpoint was significantly lower in the early BMV group than in the conventionally treated group. Now, this is not a randomized trial, as I said, but we finally have some evidence that early BMV in moderate MS is worth the risk. I'm Peter Block, and this is a CardioSource Heart Minute.